Hi everyone, it's Joe Cabaret here in Camarillo, California, here to talk about buprenorphine for chronic pain, transforming our most challenging patients into our greatest success stories. I have nothing to disclose right now. I am the founder and CEO of my own pain practice in Camarillo, California, but I have no relationships with any of the drug manufacturers that make buprenorphine. I don't do any research in the field of buprenorphine. I'm board certified in anesthesiology, pain medicine, and addiction medicine, past president of the California Society of Interventional Pain Physicians, senior advisor at Pacific Spine and Pain Society. I'm an instructor of interventional techniques. I have my own support group, and I am a co-author of a book on regenerative medicine by ACIP. Let's talk about chronic pain. This is a talk about buprenorphine for chronic pain. So chronic pain is any pain lasting greater than 3 months. It is very prevalent, more common than diabetes, heart disease, and cancer combined, and it's substantially increased over the last 2 decades. 20% of U.S. adults are affected, 8% are affected by high impact pain, which limits life activities, and left untreated, it leads to a whole host of coexisting disorders like depression, anxiety, insomnia, fatigue, reduced quality of life and function, and even employment restrictions. The Pain Management Best Practices Interagency Task Force, which is comprised of the Department of Health and Human Services, Department of Defense, and the Office of National Drug Control Policy, described the current state of chronic pain care as a crisis with profound societal costs. In the non-opioid treatment landscape, all medications, not just the opioids, need to be selected based on diagnosis, pain mechanisms, comorbidities, and only after a thorough workup and risk-benefit analysis. And it turns out the non-opioid drugs carry significant risks. NSAIDs, acetaminophen, antidepressants, anti-seizure meds, all the different classes carry risks of their own that are quite significant. And conventional opioids have no evidence for long-term efficacy. Great short-term drugs, but long-term there's zero evidence that they are effective. And this is due to tolerance and dependence, sometimes called opioid-induced hyperalgesia or OIH, and they have a host of potential risks. Unwanted effects are due to the mechanism of action, which is full binding to mu receptors in the central nervous system. Mu activation leads to opioid-induced hyperalgesia, which is tolerance and dependence. It also contributes to the side effects, including sedation, respiratory depression, most importantly, constipation, nausea, vomiting, immunosuppression, irritability, anxiety, insomnia, and pruritus. Mu activation also triggers the reward pathway, leading to risks of opioid use disorder and its sequelae. In fact, for this reason, opioids are not considered first line for chronic pain. But opioid use disorders and overdose deaths are really just the tip of the iceberg. There are many long-term opioid users who are chronic pain patients without addiction, who are suffering from loss of effect, opioid-induced hyperalgesia, and side effects, and really unnecessarily, as I hope this talk will make clear. Buprenorphine is different. It's underutilized and overlooked. It's derived from the poppy opium alkaloid thebaine. It's a mixed action agonist-antagonist at the 4 non-opioid receptors, and it's a DEA Schedule III drug, so it's easy to phone in and you can put refills on it. It has these unique pharmacodynamics that induce potent analgesia with fewer side effects, and perhaps most importantly is this unique ceiling effect for respiratory depression, but not for analgesia. If you look at this graph, the x-axis shows the dose going up, and the y-axis shows the opioid effect, and the orange line is conventional opioids. And you can see that after achieving analgesia, as the dose goes up, they rapidly lead to respiratory depression. But buprenorphine, the blue line, has a more, after achieving analgesia, the curve kind of flattens out. And so as the dose goes up, respiratory depression does not. The risk for respiratory depression does not. It's a slower curve. These are the 4 non-opioid receptors, and buprenorphine is a partial agonist at the mu receptor. It's an antagonist at the delta and kappa receptors, and it's an agonist at the ORL1, or opioid receptor-like 1 receptor. Let's look at each one of these individually. At the mu receptor, it's a partial agonist. Probably very few of you realize that conventional opioid binding to the mu receptor activates 2 intracellular downstream signaling pathways. The G protein pathway, which leads to analgesia, good, and the beta-arrestin pathway, which leads to side effects and inhibition of analgesia, bad. Buprenorphine preferentially activates this good G protein signaling over the bad beta-arrestin signaling, which leads to greater efficacy and a more favorable side effect profile. Buprenorphine also facilitates migration of mu receptors to the cell membranes, which also contributes to enhanced analgesia. Buprenorphine also dissociates more slowly from the receptors, from the mu receptors, resulting in prolonged analgesia and lower end-of-dose withdrawal pain. In fact, this high affinity and tight binding to mu receptors is what blocks cravings and withdrawals and confers competitive inhibition against full or pure mu-agonists, which prohibits their euphoric effects, and which is the basis for their use in opioid use disorder. But today's talk isn't about opioid use disorder. It's about chronic pain, and specifically buprenorphine for chronic pain. At the delta and kappa receptors, it's an antagonist. This results in less likely respiratory depression, sedation, dysphoria, constipation, immunosuppression, tolerance, and opioid-induced hyperalgesia, and may also potentiate the antidepressant, anxiolytic, and anti-hostility effects with reduced suicidal tendencies that we see with buprenorphine. Buprenorphine is now being studied in the psychiatric literature for treatment-resistant depression. The ORL1 receptor agonism blocks the reward system, which slows tolerance, resulting in better long-term efficacy and lower abuse potential. ORL1 receptor activation in the spinal cord may also contribute to its analgesic efficacy, which brings me to this point of tissue specificity. Buprenorphine preferentially activates spinal versus supraspinal mu receptors, and this gives great analgesia while limiting euphoria and respiratory depression. So it has this sublingual intrathecal pump-like properties, if you will. Other advantages include less immunosuppression and less constipation. And I want to talk about some misconceptions, because there are a lot of misconceptions about buprenorphine in the U.S. While it's better known in the U.S. for opioid use disorder, buprenorphine was in fact developed and used as an analgesic for severe pain in Europe for over 3 decades before its FDA approval for OUD in the U.S., which was around 2002. Classification as a partial agonist based on in vitro studies has been misconstrued as partial analgesic efficacy. And as we saw from that previous slide, partial agonism really refers to G protein versus beta-arrestin activation. So analgesia versus side effects. It's not partial analgesia. In fact, in clinical studies for various conditions, including acute surgical and renal colic pain, chronic cancer, and non-cancer pain, buprenorphine has demonstrated analgesic and anti-hyperalgesic efficacy equal or superior to full pure mu-agonists such as morphine, oxycodone, fentanyl, and sufentanil. In fact, buprenorphine is really 25 to 100 times more potent than morphine. And when you think about it, we use 2, 6, 12 milligrams as opposed to the hundreds of milligrams patients are using of morphine. While often considered only after failure of conventional opioids in this country, really that interagency task force I talked about earlier is recommending buprenorphine as primary therapy before traditional opioids due to its superior efficacy, greater tolerability, and lower risk for respiratory depression. How does it come? Well, oral bioavailability is only 15%, but it has great transdermal and transmucosal bioavailability. So it comes transmucosally and transdermally in the United States. We have a buprenorphine patch, and the brand name is Butrans patch, but it now comes generically as well. And this is suitable for less than 80 morphine milliequivalents per day. And this drug is indicated for chronic severe pain, not for addiction. There's also the Belbuca film, which is a buccal formulation. It goes into the cheek, and it's suitable for less than 160 morphine milliequivalents per day, and is also FDA indicated for chronic severe pain, not for addiction. And then we have the sublingual formulation that we're all more familiar with, Subutex, Suboxone, Zubsolv, and this is suitable for any morphine milliequivalent dose off-label for pain, but it is FDA indicated for opioid use disorder, and that requires the DEA X license or the Data 2000, which is otherwise known as the Data 2000 waiver in order to prescribe for opioid use disorder. But this talk is about pain, okay? And I use the sublingual formulation probably more than any of the others in my practice for chronic pain. It is a great medication for chronic pain. So let's recap So far, we've discovered that this is a Schedule III narcotic for which generics are available, so it's easy to prescribe. It's got these unique multiple mechanisms of action which confer specific advantages over traditional opioids. There's less respiratory depression, less risk for fatal overdose. It has this long half-life and clinical effect, which leads to lower end-of-dose withdrawal and perhaps contributes to better sleep. It has less side effects, greater tolerability. It has antidepressant and anxiolytic effects which improve mood and perhaps also sleep. There's less tolerance and hyperalgesia, so greater long-term efficacy. There's less euphoria and abuse potential. Works great for coexisting opioid use disorder, and many of these patients have a mild, moderate, or severe opioid use disorder concomitantly with their pain disorder. Tissue specificity for the spinal cord, it's a little bit like having an intrathecal pump that works sublingually, and it has superior efficacy and better pain relief. Superior pain relief to traditional opioids. And the fact that it comes in transdermal, buccal, and sublingual formulations really avoids the GI tract, which can be very advantageous, as we'll see in some of our future slides. But wait, there's more. I want to talk about specific populations, particularly cancer pain, neuropathic pain, older adults, and impaired renal function. When we look at cancer pain, a third of cancer patients report moderate to severe pain. And randomized controlled trials have demonstrated efficacy of buprenorphine in cancer pain. A multi-center RCT showed buprenorphine for cancer pain as effective as Schedule II morphine, oxycodone, and fentanyl. And systematic review also showed efficacy comparable to fentanyl, but lower risk for analgesic tolerance and better tolerability. The transdermal, sublingual, and buccal formulations are also especially useful in cancer patients who can't swallow or who have chemotherapy-induced nausea and vomiting. You know, traditional opioids really don't work for neuropathic pain. It's unfortunate that they're prescribed so often for neuropathic pain conditions. But buprenorphine does dampen central sensitization and may possess distinct analgesic mechanisms in neuropathic pain, including differences in signal transduction. In fact, the consensus panel on opioids and pain concluded that buprenorphine shows a distinct benefit in improving neuropathic pain. Conventional opioids cannot claim that. In older adults, pain becomes more common and treatment options narrow due to, polypharmacy, comorbidities, slower metabolism, pharmacokinetic and pharmacodynamic changes. But because it's highly bound to globulin, buprenorphine has less drug-drug interactions. It's also shown that in PK studies that the average buprenorphine exposure at steady state was only slightly lower in the over 75 age group. And buprenorphine showed higher or similar analgesic efficacy in the over 65 age group, but while conventional opioids had increased risk for fracture, buprenorphine did not. And it was thought that this was due to less dizziness. A retrospective analysis, in fact, demonstrated similar incidence of adverse effects in patients over and under 65 years of age. In impaired renal function, conventional opioids have a risk of toxicity due to accumulation of active metabolites. But buprenorphine is primarily eliminated by the liver, and plasma concentrations are comparable regardless of renal function. In fact, buprenorphine can be used safely even in dialysis-dependent patients. So I want to summarize and add to our previous summary that, we learned that these medications are easier to prescribe. And so if you're going to pay attention to any slide, this kind of sums it all up. It has this unique mechanism of action, which has specific advantages. There's less fatal overdose risk, perhaps the greatest advantage of all. Better sleep, less end-of-dose withdrawal, greater tolerability, better mood, greater long-term efficacy. It has less euphoria and abuse potential, works great with coexisting opioid use disorder, as so many patients on opioids for pain have perhaps mild opioid use disorder. It works preferentially in the spinal cord, a little bit like an intrathecal pump, and it has superior efficacy and better pain relief. The other important point to bring up about buprenorphine, and I'm going to talk a little bit about that in the next slide. It has transdermal, buccal, and sublingual formulations which avoid the GI tract, and that can be a very good thing, and it is a very good thing in my practice. It's very fast acting, by the way. People take this medication, and within 15 minutes it's working, as opposed to the 45 to 60 minutes it takes for a PO medication to work. And patients really like that. In addition to all these advantages that we looked at earlier, it's great for cancer pain, great for neuropathic pain, great for older adults. It's safe in renal impairment. There's less fracture risk, and there's no immunosuppression. So it looks like a no-brainer on paper, right? But I want to talk about my experience, my clinical experience, and a picture paints 1,000 words. These are pictures of patients with addiction before and after treatment. And, you can see in their eyes, you can see in their smiles, in their skin, in their overall demeanor, the difference before and after. And I'll tell you that patients using opioids for chronic pain, even who don't have addiction, often have that exhausted look, that strung out look, if you will, especially if they're now taking benzos in addition to their opioids to treat the long-term opioid side effects. And, when I start someone on buprenorphine, even after all these years, it still amazes me when they come back. I'm still very pleasantly surprised to see the change in their whole persona. Sometimes I barely recognize the patients. Their eyes are softer, their smiles are brighter, their skin is clearer, they look 15 years younger, they move differently, they laugh differently. They have different personalities. They are just a delight to see. And they say that their family and friends notice all this. They sleep better. And almost all of them say, my pain is better. Many of them say, my pain is gone. I don't have pain anymore. And they were planning surgeries and we were planning injections and, they were desperate for pain relief. And now their pain is better. And so it's pretty amazing to see, even now after all these years, it's very rewarding to see. And I just can't say enough about what a miracle drug this has been in my practice for patients who've been on long-term opioid therapy. But there are some barriers to entry with this drug. And one is it's a difficult sell. Patients who've been taking opioids chronically don't want to give up their opioids. And, that tells you something as well. When I say to a pain patient who comes to see me for pain that I have a medication that's going to work better for their pain, and they say no thanks, that kind of tells me that there's more than just pain going on. There's an unhealthy attachment to the medication that they're currently taking. And so it requires a lot of motivational interviewing. Not everybody likes to do that. Not everybody's good at that. It's something that I really enjoy and that I'm really good at. There's also this thing with, the opioid use disorder baggage. And a lot of patients have heard of it, or their friends use it, or they look it up and they say, hey, this is for addiction. You calling me an addict? I have chronic pain. And it takes some time. Again, you have to have the patience and the wherewithal and the temperament to sit there and explain to people that you're using this for their pain, not for opioid use disorder. And, the other thing about opioids, about Suboxone, is it's kind of a tricky induction. You can't just go from taking a pure MU-AGONIST to buprenorphine, quickly. Patients have to go at least 12 hours, depending really on the dose that they're on. It could be more than 12 hours without their opioids, and they have to be in moderate withdrawal before they start Suboxone. So this is really scary for a lot of patients and can be a barrier to entry. It's also trickier to use around surgeries and hospitalizations. Usually the surgeons and hospitalists aren't that familiar with this drug, and it might not be on formulary, and so it makes it more difficult to use in those situations. A lot of patients come off of the buprenorphine during their hospital stays or during their surgical period and then go back on afterward. But I've used it a lot now all through the perioperative period, and it is a great drug for surgical pain as well. And the last thing is, if you're going to be using Suboxone, you need this DEA X license, or otherwise known as the Data 2000 waiver, in order to prescribe it for pain. And that can be, I use Suboxone probably more than any of the other formulations in my practice. It's cheaper and easier, and it gives me more flexibility. When I say easier to initially dose, because patients really kind of need to find their dose over the first few days. Some people get there really quickly. Some patients struggle more early on. And, it takes a lot of patience. And so if this is all something that sounds like, too much for you or something you're not really interested in doing, you could send me these patients, and I guarantee you're going to see a lot of happy patients come back to you. Patients who perhaps were your most challenging patients come back as real success stories after switching to Suboxone. But it's not always immediate. This can take time. This can take years for me to, motivate them to make the switch. And then even after they make the switch, sometimes it takes a few days or even a few weeks to really get them settled into this new normal. And once they do, they just love it. So if you have any questions, if you want to learn more about this, if you want to send me patients, This is all my contact information. My cell phone is at the bottom. That's my personal email at the bottom. You should have all my contact information in the webinar invitation materials that were sent to you as well. I love taking questions about this stuff. This is my passion, really. So, I mean, I'm an interventional pain doctor. I do regenerative medicine. I do all the procedures, all the surgeries, spinal cord stimulators. But this is what I love to do the most. I really love to see patients just come back in with that smile on their face. All right. Thanks for your time.